going to talk a little bit about the medical model, and obviously I'm a GP and I was trained in the medical model. And before I continue on with that, I just had an interesting challenge recently. I wrote an article for a GP medical journal, a general article, information about abuse and how GPs need to be aware of it, what to look for, how to ask, where to refer. When I first put the article to them, they said, "Not for us. We don't need to know about it. It's not something that, is important." I had to take that back to the board, and that was a deliberation on the board. It took several months, and I then went through the most protracted review process. I don't know that it's normal that you normally have 5 or 6 reviewers, but I felt like I was being put through the mill. Eventually got the article in, but I mean that actually says a lot. The absolute resistance and denial out there, the people who are the first line people often that survivors will present to don't want to know. So the medical model, designed to diagnose, to apply a disease, to label a group of symptoms, and physical diseases fit very well into this. You can, and I was a trained monkey, you learn your lists of symptoms and signs, and you put a label on it and you respond accordingly. It works. Sometimes it works. But with trauma, it's much, much harder to fit conditions into a medical model. And that seems to be why we end up with an array of diagnoses. I was speaking to Miranda earlier, and she beat me. She said she had 18 diagnoses. I think I only have about 10, so I think she won. And of course, this is a problem in and of itself. It's obviously the wrong approach. When I was in the midst of dealing with my stuff, I think I was my own walking DSM-4. Anxiety disorders, depression, panic, suicidality, PTSD, complex PTSD, dissociative disorders. But none of those diagnoses captured the essence of what was going on with me. But thankfully, I had a therapist who didn't pathologise me. Of course, I've sent her overseas several times with the therapy, but I suppose at least I'm relatively well. The premise of the medical model is the principle that something is wrong with a person, rather than looking to see what wrong was done to the person, what happened to the person, why is it so. And I did develop a range of mental health challenges because of what had happened to me. And as one of my medical colleagues and a friend, still a friend at that time, put it so delicately, "You're not becoming one of those mental health patients, are you?" So, yes, well, actually, maybe I was, but I also needed to be understood rather than being judged and ostracised. Common to all survivors, what I needed was empathy, compassion, understanding. My medical health challenges were normal reactions to extremely abnormal circumstances, and appreciating that is fundamental to the move to embrace a trauma-informed approach to care. Rather than articulating a diagnosis, it's critical that anyone interacting with survivors understands the effects traumatic life events have on the development of individuals. For me, finding a therapist who could validate the way I was feeling, who could bear witness, as someone said this morning, who I could learn to trust, and that took one hell of a long time, having been betrayed so badly, who could make me feel safe and be safe, and who could listen empathically, who really just walked alongside me, contained my angst. That was absolutely crucial for my recovery. I spent 2 years on the edge of the gap, and without her, I would have been on the other side, and that was absolutely vital. I don't know that I'll talk too much about borderline personality disorder. I think it's taken quite a beating already today. Not that I don't personally think that it shouldn't take a beating. I think it's a very pathologising diagnosis, stigmatising, and again, it captures a symptom profile, but it doesn't capture a person and their lived experience. And, you know, certainly if we can try and understand it, at least, the behaviours, at least in terms of traumatic stress, personal invalidation, disrupted attachment, and adaptive coping strategies, it will help us to provide care and support to people who are experiencing those presentations. So in recent years, cognitive behaviour therapy, exposure, cognitive restructuring have been used extensively as evidence-based, and we hear those terms all the time, responses to PTSD. Not to say that they aren't of value, but when they're applied to people who are experiencing complex trauma, especially prior to the establishment of safety, we can have problems. Working through the compounded impacts of trauma can take a hell of a long time and involves a number of stages. And obviously there's lots of theories, but you know, this is one. Safety, developing a therapeutic relationship, developing skills, education, processing, integration. And the failure of practitioners, systems, workers and governments to appreciate these complexities means that survivors of childhood abuse do not find the care and support they need to reclaim their health and well-being. So talking about services in Australia, sadly in Australia, adult survivors with complex needs really struggle to find services in which workers are adequately trained around trauma. Systems are overstretched, services tend to focus on crisis and risk management, delivering short-term rather than long-term interventions which are really needed for sustained recovery. We've heard people talking about revolving doors. You know, that's what we want to avoid. In many cities and towns, it's really hard to access expert, long-term, affordable counselling and therapy, skilled groups, workshops, and in rural and regional areas, probably not worth even trying. Current systems commonly label and pathologise survivors in their presentations, and an inherent lack of understanding and awareness about potential triggers leaves them at risk of re-traumatisation. This means survivors experience services being unsafe, disempowering and invalidating. Characteristically, survivors shop around because they just can't find a service to meet their needs, and oftentimes they give up. I mean, we have people who come to us who've had such a bad experience with one counsellor or another that they go underground for another 10 years. It's really very hard to find good services. And this goes across government, non-government, community, public, private sector. Oftentimes they're left not knowing where to turn, and they do give up. There are exceptions, of course. There are some services that are sensitive to survivors' needs, but they are few and far between. And often they depend on an individual rather than a service culture. And when the individual leaves, so does that person's chance of getting appropriate care. Trauma survivors with complex needs often experience comorbid mental health and substance abuse issues, as well as a range of life burdens. These findings are supported by extensive research. The majority of clients, the vast majority of clients presenting to mental health and alcohol and drug services with trauma have trauma histories that are integrally intertwined with their presentations and their substance abuse and mental health challenges. Yet, despite you'd think it would be patently obvious that you'd handle all of these issues together, that very rarely happens in an integrated way. Care for survivors with comorbidity is fragmented and fails to respond to their multiple needs. And they can include welfare dependency, homelessness, social inclusion, unemployment. A holistic approach to care and support is needed, and yet to date we see little coordination between services, poor referral and follow-up pathways. So what do adult survivors of childhood trauma need? As I said, I'm a medical practitioner by training, and I apologise for that. The Hippocratic Oath states, "First do no harm." However, harm is often done to trauma survivors when their trauma goes unacknowledged and when their particular vulnerabilities and sensitivities are disrespected and misunderstood. Harm is done when survivors are labelled and negated as human beings and as individuals, disaffirming their traumatic experiences at the very core of their being. At the most basic level, trauma-informed care involves the provision of services that do no harm, that do not re-traumatise victims or blame them for their efforts to manage their own traumatic reactions. So what do we need to do to support survivors? And again, this is really common sense. We need to recognise the adaptive function of symptoms and work in a collaborative and empowering way. We need to understand the symptom as an adaptation, and by doing so we reduce guilt and shame, increase self-esteem, and provide a pathway for developing new skills and better adaptations. We also need to validate resilience, even when past adaptations and ways of coping are causing problems in the present. Survivors need to feel understood, have their experiences heard and validated, and find a sense of belonging. Survivors also generally benefit from making connections between their past experiences and their current situation as part of an integrated recovery journey, enabling them to ultimately view their abuse as part rather than all of them. It was interesting, I once spoke to one of our members and I said, Paul, you know, you're more than just your abuse. And he came back to me the next day, he hadn't slept all night. I'd actually inadvertently removed his identity. That was who he was at that time. And I felt devastated for having done that. We need to also acknowledge survivors' strengths and their other social roles. But of course, none of this can be done in isolation. Relationships are crucial to the process of recovery, but the nature of those relationships is absolutely vital. As the relationships which caused the original trauma were disempowering and controlling, relationships of care and support must challenge the beliefs of the original trauma. They must be safe, consistent, constructive, supportive, non-violent, non-blaming, non-shaming, featuring persuasion and not coercion, ideas and not force, mutuality rather than authoritarian control. Predictable environments, clear boundaries, well-defined roles all allow survivors to feel empowered and rebuild a sense of self-efficacy and personal control. These factors are absolutely essential to recovering from the overwhelming fear and helplessness that is the legacy of victimisation. Approaches should be collaboratively and mutually respectful, with survivors setting the pace. And certainly, you know, that was an issue in my own therapy. I thought my therapist was very skilled, but whenever she tried to push me just a little bit harder, it actually caused me to dissociate far more severely and put me backwards. And she learnt very quickly that I had to set the pace, no matter how slow it was and how painstaking it was. All of this allows survivors to build on their strengths and their resiliency and to develop their coping skills, more constructive coping skills, hopefully, embrace hope and work towards a positive future.